Welcome to the deep dive. We're here to really dig into core surgical knowledge, pulling directly from the key texts and research.
That's the idea.
Today, it's all about abdominal wall hernias. We're using Bailey and Love as our guide to build a complete picture anatomy, pathology, management, the works.
Exactly. Think of this as a structured masterclass. If you need the foundational understanding of hernia anatomy, the tricky bits of pathology, diagnosis, and modern surgical thinking, this is for you. We want to make this complex chapter immediately usable.
So our mission is pretty clear. Break down why the abdominal wall fails. Get the definitions and classifications straight, really understand this mesh technology everyone talks about, and cover the surgical and non-surgical options. Ready to jump in?
Let's do it.
Okay, the abdominal wall. The source starts by highlighting this paradox, doesn't it? It needs to be tough, protective.
Absolutely. A shield.
But it also has to let us move, bend, twist, expand. How does that need for flexibility create weakness?
It really comes down to elasticity and pressure. To be flexible, the wall needs elastic components, fascia and muscle that can stretch and recoil. But pure strength often relies on rigidity. So there's an inherent trade-off.
And you mentioned pressure.
Right. There's a constant pressure game going on. Above the diaphragm in the chest, you actually have negative pressure. It sort of sucks things upwards.
Hence the risk of diaphragmatic hernias, like Morgagni.
Precisely. Morgagni, Bachdolek, those are examples of contents being pulled up. But below the diaphragm, in the abdomen itself, it's the opposite.
Positive pressure, pushing outwards.
Exactly. And things like coughing, lifting, straining, they massively spike that internal pressure. It's always looking for a weak spot, a path of least resistance.
So where are these built-in weak spots? Where does the pressure usually find an escape route?
Well, posteriorly, it's pretty solid. You've got the vertebral column, the ribs giving a strong anchor.
Yeah.
But even back there, you find the posterior lumbar triangles, the superior one, Grinfeld shaft, and the inferior petite. They're rare spots for hernias, lumbar hernias, but they are defined weaknesses.
And laterally?
Laterally, you have those three layers of muscle: external oblique, internal oblique, transversus abdominis. They run in different directions, crisscrossing. It gives strength and flexibility. A pretty clever design, actually.
But most hernias we see aren't posterior or lateral, are they? It's the front.
That's the main battleground, yes. Particularly the midline. You have the two big, powerful rectus abdominis muscles running vertically. They're strong themselves.
But the joint between them.
That's the linea alba. It's a fibrous seam, essentially, and that seam is a major structural vulnerability. It's where you get your epigastric hernias higher up and your umbilical hernias around the belly button. It's like a fault line.
Which brings us nicely to something that looks like a hernia but isn't devarication of the recti. Why is it so important to get this distinction right?
Oh, absolutely critical. Because you don't want to operate unnecessarily. Devarication is basically a stretching and thinning of that linea alba. The two rectus muscles just move further apart laterally.
Okay.
You see it a lot in middle-aged guys, maybe carrying a bit of extra weight, often in the upper abdomen, and very commonly in women after pregnancy, usually below the umbilicus.
And the key difference from a true hernia, what's missing?
There's no actual defect. There's no hole or opening with defined edges that tissue can get trapped in. It's just thinned out fascia.
So no risk of strangulation.
Exactly. That's the crucial point. Since there's no tight ring to constrict blood supply, strangulation isn't a concern with devarication. It might be a cosmetic issue for some people, and Bailey and Love mentions cosmetic repair is sometimes done, but generally no treatment needed. Making that distinction saves patients from potentially needless surgery.
Okay, so we know where the wall is weak. Let's pin down the definition. A hernia is an abnormal protrusion of an organ or tissue through an opening in its normal confining layer.
That's the textbook definition. And specifically in the abdomen, as that organ or tissue pushes out, it tends to drag the layers of the abdominal wall with it. These become the coverings of the hernia.
And usually there's a sac.
Yeah.
Made of peritoneum.
Usually, yes. Most abdominal hernias push out the peritoneum, forming a sac, but it's not universal. Like we touched on, some small epigastric hernias might just start as a little plug of fat from outside the peritoneum, what's sometimes called a lipoma of the cord or sac, and only later does the peritoneum get involved, so it's a nuance to remember.
The book lays out 4 main reasons these happen. Summary box 64.1.
Oops.
We've covered anatomical weak spots. What about developmental issues?
Ah, yes. Developmental failures are huge. This is the cause of the most common type of hernia overall, the indirect inguinal hernia.
Right.
It happens because a structure called the processus vaginalis fails to close completely. This is the little pouch of peritoneum that comes down with the testicle during development. If it stays open or partially open, it leaves a direct path for abdominal contents to follow.
And the source mentioned some interesting potential triggers for that failure. Hormones.
Yeah, some research suggests things like calcitonin gene-related peptide, maybe hepatocyte growth factor, might play a role in whether that process obliterates properly. It hints that it's not just a random mechanical failure. There could be a biochemical element.
Fascinating. Then there's the third cause, this idea of a collagen disease. This sounds more systemic.
It really does. There's pretty compelling evidence for a genetic predisposition in many hernia patients. The thinking is that it's about an inherited imbalance in collagen types.
Collagen type I versus type 3.
Exactly. Type I collagen is the thick, strong stuff, gives tissue its tensile strength. Type 3 is thinner, more elastic, less robust. People prone to hernias, especially those who get recurrent ones, seem to have relatively less type I and more type 3. Their basic connective tissue is just inherently weaker, less organized.
And this connects to other conditions too.
It does. You see statistical links between hernias and things like aortic aneurysms, emphysema, other conditions where collagen is implicated, and smoking makes it worse.
How so?
Smoking directly messes with collagen maturation. So if you already have a slate imbalance, smoking compounds the problem. Explains why smokers have higher hernia rates and do worse after repair. And in extreme genetic conditions like Ehlers-Danlos syndrome, the collagen is so profoundly abnormal that getting any kind of hernia repair to hold long-term is incredibly challenging.
Wow. Okay, and the last category, acquired weakness. Mainly surgical scars, right? Incisional hernias.
That's the big one here. Even a perfectly healed surgical scar is never as strong as the original tissue. It only gets back about 70% of the tensile strength.
Only 70%.
Yeah. Which means if you have a major abdominal incision, a laparotomy, your risk of eventually developing an incisional hernia is significant. The book quotes at least 10%. It can be higher.
But keyhole surgery is better.
Much better in this regard. Laparoscopic port sites have a much lower risk, maybe around 1%, just because the defect is so much smaller. You can also get traumatic hernias from massive force, like a car crash, but those are rare.
So once the hernia forms, the danger level really depends on the neck of the hernia, right? Where it passes through the abdominal wall defect.
Absolutely. The neck is the critical point. If the defect is small and the edges are really firm, unyielding, think of the femoral canal. It acts like a bottleneck, a tight bottleneck.
And that dictates the complications. Summary box 64.2.
Precisely. We have to be very specific about the state of the hernia. If the contents slide in and out easily, it's reducible. Simple.
And if it gets stuck?
If it's stuck, it's irreducible. This often happens because of adhesions forming inside the sac or just because the neck is too tight. We also use the term incarcerated, literally meaning imprisoned. It implies it's stuck and potentially heading towards trouble.
And that trouble means acute complications.
Yes. The first stage might be obstruction. This means the bowel loop inside the hernia is blocked, causing symptoms of bowel obstruction. But importantly, the blood supply is still okay for now.
But the real emergency is
Strangulation. This is where the neck is so tight it cuts off the blood flow, first the venous outflow, then the arterial inflow. The tissue becomes ischemic, starts to die, turns gangrenous. This is a life-threatening surgical emergency, needs surgery now.
We have to highlight that particularly dangerous variant, Richter's hernia. Why is it such a trap?
Richter's. It's treacherous because only a part of the bowel wall, usually the side opposite the mesenteric blood supply, gets trapped in the hernia defect.
Just a little knuckle of bowel wall.
Exactly. And because the main channel of the bowel isn't blocked, the patient might not have the classic signs of obstruction. They might not be vomiting or completely constipated.
So diagnosis is delayed.
Often, yes. They might just have severe localized pain over the hernia site, but that little piece of bowel wall is still strangulating. It can become necrotic, perforate, and lead to overwhelming sepsis, even while the patient is still passing stool. Bailey and Love points out it's common in femoral hernias because the defect there is so sharp and tight, a real diagnostic pitfall.
Okay, moving into the clinic. You're right, often the patient comes in saying, I think I have a hernia. They might feel an ache, a heaviness.
Yeah, self-diagnosis is common. But if they describe sharp stabbing pains, that's a worry. It suggests tissue is getting pinched intermittently at the neck. Severe, constant pain, that screams strangulation alert.
And the history needs to clarify. Is this new? Is it recurrent after a previous repair? Is it at an old scar?
Absolutely. Because the management strategy might differ significantly.
Yeah.
And of course, standard stuff, check their overall fitness, heart, lungs, any medications like blood thinners that affect anesthesia or surgery.
Then the examination, summary box 64.4. This is where the hands-on skill comes in. What's the process?
You need to examine them lying down first, then standing up. Sometimes you need to ask them to cough or strain the Valsalva maneuver to make the hernia pop out.
And the key sign you're looking for?
The cough impulse. You gently place your fingers over the lump. When the patient coughs, a reducible hernia should give you a distinct expansile impulse. You feel it push outwards against your fingers as the pressure increases.
But if you don't feel that outward push,
That's a red flag, a big one. If the lump is there but it doesn't expand on coughing, it strongly suggests the neck is tight and the contents are irreducible, trapped.
like in a femoral hernia.
Classic finding in a femoral hernia. It's often small, doesn't bulge much on coughing, and feels firm. That's why it gets mistaken for an enlarged lymph node, which also wouldn't have an expansile cough impulse.
What else are you checking during the exam? Summary box 64.3.
You need to check the skin over it. Any redness, heat, tenderness suggesting inflammation or strangulation. That's an emergency. Can you reduce it? Is it tender? Have they had surgery there before? You feel for scars. And critically, always examine the other side.
Why always the other side?
Because up to 20% of patients might have a hidden asymptomatic hernia on the contralateral side. Finding it means you can potentially fix both at the same time, saving them another operation down the line.
And if it seems irreducible?
Ask the patient to try and reduce it first. They often have their own technique, they're more relaxed. If they can't, and you can't gently reduce it, then the urgency for treatment definitely goes up.
Most hernias are diagnosed clinically, but imaging, summary box 64.5, has its place, right?
Definitely. Clinical diagnosis is king for straightforward cases, but imaging helps in tricky situations.
Like ultrasound.
Ultrasound US is great for groin lumps you're not sure about. Is it a hernia, or maybe a lymph node, or a saphenous varix that's a varicose bulge of the saphenous vein, or even just a fatty lipoma? Ultrasound is dynamic. You can see things moving with coughing or pressure, which is useful, but it's very operator dependent. The quality of the scan depends hugely on who's doing it.
When do you need the bigger guns, like CT?
Computed tomography, CT, is essential for complex hernias, especially big ventral hernias or incisional ones. You need CT to map out the anatomy. How many defects are there? How big are they? Where are the edges of the rectus muscles? It's crucial for planning complex abdominal wall reconstruction. And, of course, if someone comes in acutely unwell with suspected bowel obstruction, CT is the go-to to confirm if a hernia is the cause.
And MRI, more specialized.
Magnetic resonance imaging, MRI, really shines for chronic groin pain, where you can't find an obvious hernia clinically, particularly for sportsman's groin or Gilmore's groin. MRI can help differentiate subtle posterior inguinal wall weakness from other causes of groin pain, like hip joint problems or adductor tendon injuries.
Can laparoscopy itself be diagnostic?
Yes, sometimes. Especially if you're doing a TAPP repair that's transabdominal perperitoneal, you get a great view from inside the abdomen. You might spot an unexpected contralateral hernia. However, laparoscopy can miss things between the layers, like small epigastric hernias or spigillian hernias that haven't fully popped through the peritoneum yet.
All right, diagnosis confirmed. Do all hernias need fixing? Summary box 64.6.
Not necessarily, but surgery is generally recommended if the hernia is causing symptoms, pain, discomfort, interfering with life, or if it's irreducible, or if it's a type known to have a high risk of complications.
Like femoral hernias.
All femoral hernias need repair. That's a hard rule. The strangulation risk is just too high. For younger adults with, say, an inguinal hernia, even if it's not bothering them much now, repair is usually advised because it's likely to cause problems eventually over their lifetime. And obviously, acute pain or irreducibility means urgent surgery.
When is it safe to just watch and wait?
Watchful waiting is a reasonable option, mainly for older, perhaps less fit, individuals with asymptomatic inguinal hernias. The yearly risk of them suddenly needing emergency surgery is relatively low, maybe around 10%. Trusses or supports are rarely helpful, by the way. Also, small umbilical or epigastric hernias that clearly just contain fat or omentum, not bowel, have a very low complication risk, so watchful waiting can be okay there too. And sometimes, paradoxically, really huge, complex, recurrent incisional hernias in frail or very obese patients are managed conservatively because The risks of another big operation and the high chance of it recurring again just outweigh the potential benefits.
If surgery is the plan, what are the basic steps?
First, you gently reduce the contents back into the abdomen. If any tissue looks dead strangulated, it has to be excised. Second, you deal with the peritoneal sac. Ideally, remove it and close the neck, but sometimes, especially in laparoscopic repairs, small sacs might be left behind.
Which can lead to seroma later.
Exactly, a collection of fluid. Third, you close the actual defect in the muscle or fascial layer, if you can without tension. And finally, you reinforce the repair. In modern adult hernia surgery, that almost always means using mesh. ### B. Deep dive into mesh technology.
Yes, it's essential now, isn't it? It's basically a prosthetic sheet or net to strengthen the repair.
Right. It can be used in a few ways. Sometimes to bridge a gap you can't close. Sometimes as a plug, though plugs are less popular now due to risks of forming a hard meshoma. But ideally, it's used to augment a repair. You close the defect primarily, then lay the mesh over it for tension-free reinforcement. That's the gold standard principle.
Now, we need to talk about mesh failure. People often say the mesh shrinks. Is that right?
That's a really common misconception, but it's not technically accurate. The synthetic mesh material itself, like polypropylene, is pretty stable dimensionally. It doesn't shrink on its own.
So what is happening?
It's the body's reaction to the mesh. The mesh acts as a foreign body, a scaffold, and it triggers an inflammatory response and scar tissue formation fibrosis. If the mesh is very dense, what we call heavyweight, it provokes a much stronger, more aggressive fibrous reaction. And it's this scar tissue that contracts over time.
Ah, so it's mesh contracture driven by the host tissue response.
Precisely. That contraction can pull the mesh inwards, effectively reducing its functional surface area, sometimes by as much as 50%. If the mesh wasn't placed with enough overlap initially, this contracture can lead straight to the hernia recurring at the edge.
So modern mesh design aims to minimize that aggressive scarring.
Yes. The trend now is towards lightweight meshes. These have thinner filaments and, crucially, large pores. The source emphasizes pores need to be at least 1 millimeter across in all directions.
Why large pores?
The idea is that large pores allow for better tissue ingrowth, but in a more organized, less dense, more elastic way. You get strong integration, but hopefully less scar plate formation, less contracture, less stiffness. This is thought to reduce the risk of recurrence and reduce that feeling of a stiff, foreign body, potentially lowering chronic pain rates.
Makes sense. What are the main types of mesh available? Summary box 64.7.
The vast majority are synthetic, usually polymers. Polypropylene is the workhorse. It's strong, inert, handles well, and resists infection reasonably well. Then there's polyester and PTFE, polytetrafluoroethylene. PTFE is interesting because it's very inert and smooth. Tissue doesn't tend to grow into it or stick to it as much.
Then there are the biological meshes.
Right. These are derived from animal or human tissue like skin dermis or pericardium that's been processed to remove all the cells, leaving just the collagen scaffold. The idea is the patient's own cells grow into this scaffold, and eventually the biological mesh gets broken down and replaced by native tissue.
Sounds ideal, but
But they are very expensive. They're also more prone to infection and breakdown, especially if placed in a contaminated field. Their exact role is still being figured out, often reserved for complex reconstructions or contaminated situations. And then there are absorbable synthetic meshes, like polyglycolic acid, generally not recommended for permanent hernia repair as they dissolve too quickly before strong scar tissue can form. Newer, slower absorbing ones exist, but long-term data is limited.
where you put the mesh matters too, doesn't it? Figure 64.8. There are different planes.
Yes, placement is key for mechanical reasons. You can put it onlay, just under the skin, but that risks skin problems or the mesh getting exposed. You can put it inlay, right in the defect like a plug, but that has high recurrence rates, generally not advised.
So the preferred spots are deeper.
Yes. The sublay position that's just behind the muscles but in front of the posterior sheath or peritoneum and the extraperitoneal plane are generally best. Why? Because the abdominal pressure itself pushes the mesh against the defect, helping to hold it in place. It's mechanically advantageous.
Which leads us to the big challenge with laparoscopic repair. The IPOM problem. Intraperitoneal onlay mesh.
Exactly. If you put a standard polypropylene mesh directly inside the abdominal cavity, touching the bowel, it will cause significant adhesions. Dense scar tissue forms between the mesh and the intestines.
Well, that's bad because
those adhesions can cause chronic pain, bowel obstruction. The mesh can even erode directly into the bowel, causing a fistula. It's a major complication risk. Figure 64.7.
So how do surgeons do laparoscopic mesh repair then?
They have to use special, much more expensive tissue-separating meshes for IPOM. These typically have one side made of standard mesh material, like polypropylene or polyester, to encourage integration with the abdominal wall, and the other side, the one facing the bowel, has a barrier layer designed to prevent adhesions. Common barriers are made of things like oxidized cellulose, or that smooth PTFE material we mentioned.
Are these barriers foolproof?
Unfortunately, no. The sources are clear. None of the current barrier technologies are 100% effective at preventing adhesions long-term. Plus, IPOM itself can cause issues, like quite severe post-operative pain in some patients that can mimic peritonitis for a day or two. That's why, whenever possible, surgeons prefer techniques that place the mesh outside the peritoneal cavity, like the extraperitoneal to TEP repair for inguinal hernias or retromuscular placement for ventral hernias. IPOM is often reserved for situations where other approaches aren't feasible, like in very obese patients or for certain complex incisional hernias.
Okay, let's turn to the most common hernia by far. The inguinal hernia, summary box 64.8, 10 times more common in men. And they come in two main flavors, indirect and direct.
That's right. And the difference is all about the relationship to key structures in the inguinal canal, specifically the inferior epigastric vessels.
So the indirect or lateral hernia.
This one starts lateral to those vessels. It emerges through the deep inguinal ring, which is a natural opening in the transversalis fascia, the deepest muscle layer's fascia. This is often the congenital type, related to that persistent processus vaginalis we talked about. Because it enters the inguinal canal at the deep ring, it follows the path of the spermatic cord downwards and outwards, potentially going all the way into the scrotum, sometimes becoming huge.
And the direct or medial hernia is different.
Completely different origin. It occurs medial to the inferior epigastric vessels. It doesn't come through the deep ring. Instead, it pushes directly through a weakened area in the posterior wall of the inguinal canal itself. This area is called Hesselbach's triangle.
Define Hesselbach's triangle for us again.
Sure. It's bordered laterally by the inferior epigastric vessels, medially by the edge of the rectus abdominis muscle sheath, and inferiorly by the inguinal ligament. The floor of this triangle is basically just transversalis fascia, maybe covered by some aponeurosis from the external oblique. It's an acquired weakness, a stretching or thinning of this floor.
And direct hernias behave differently.
Yes. Typically, they have a broader base. They don't have that narrow neck coming through the deep ring, so they are generally much less likely to strangulate compared to indirect hernias. Sometimes the bladder can get pulled into a direct hernia sac, which is something to be aware of during repair.
Clinically telling them apart can be tricky, though, even for experts.
It can be surprisingly difficult sometimes, especially with large hernias. There's the classic test, press over the deep ring, midpoint of the inguinal ligament. If the hernia stays in when they cough, it's likely indirect. If it bulges out medial to your finger, it's likely direct, but it's not foolproof. That's why classification systems like the EHS one are useful. They note primary recurrent, PR, location, LMF for lateral medial femoral, and the defect size, like L2 for a 1.5, 3 centimeter lateral defect. It standardizes things for reporting outcomes.
Let's talk repair, summary box 64.9. In kids, just fixing the sac herniotomy is enough, but not in adults.
In adults, just removing the sac leads to very high recurrence rates. You need to reinforce the posterior wall. Historically, this was done with sutures.
Like the Bassini repair.
Bassini was the standard for a century, suturing the conjoint tendon down to the inguinal ligament, but it creates tension, and recurrence rates are quite high by modern standards. The Schultes repair from Canada was a big improvement.
How does that work?
It's a meticulous, multi-layered suture repair of the posterior wall, aiming for a tension-free closure. In specialized centers, the results are excellent. Recurrence under 2%. But it's technically demanding, takes time, and the results depend heavily on surgeon skill. There were other suture techniques too, like the Maloney-Darn or the Sarda repair, using a strip of external oblique fascia, good options, where mesh might be unavailable or too costly.
But then came mesh, the Liechtenstein open mesh repair.
This really changed the game for inguinal hernias. It's based on that tension-free principle. Instead of pulling tissues together, you simply lay a flat piece of polypropylene mesh over the weakened posterior wall, slit it to go around the spermatic cord, and suture it loosely in place.
And the advantages?
It's relatively simple to learn, reproducible, and importantly, it significantly reduced recurrence rates compared to most suture repairs, especially in the first few years. Recovery was often quicker too. It became the dominant open technique.
But it came with a downside.
Chronic pain, that's the Achilles heel of the Liechtenstein repair. While recurrence dropped, the incidence of chronic groin pain lasting more than 3 months went up. It can affect up to 20% of patients to some degree.
Why does the mesh cause pain?
It's usually nerve-related. Either the ilioinguinal, iliohypogastric, or genitofemoral nerves get inadvertently injured during dissection, trapped in a suture, or chronically irritated by the mesh itself or the inflammatory reaction around it.
Which led to the rise of laparoscopic repair.
Exactly. A major driver for laparoscopic approaches was the potential to reduce chronic pain. The two main techniques are TAP, totally extraperitoneal, and TAPP, transabdominal perperitoneal.
What's the goal for both?
Both aim to place a large piece of mesh, typically 10 by 15 centimeters, in the perperitoneal space. That's the space behind the abdominal muscles, but in front of the peritoneum. This position covers all potential hernia sites: the deep ring for indirect, Hesselbach's triangle for direct, and the femoral canal opening. It's a comprehensive repair from the inside.
Tell the difference between TEP and TTP again.
TEP is done entirely within that perperitoneal space. The surgeon creates the space, usually with a balloon dissector, and works within it, never actually entering the main abdominal cavity. TNTP involves going into the abdomen with the camera first, then cutting open the peritoneum overlying the inguinal region, placing the mesh in the perperitoneal space, and finally sewing the peritoneum closed over the mesh.
Pros and cons.
TP avoids violating the peritoneal cavity, so theoretically less risk of adhesions to the bowel later on. But it can be technically harder, especially the initial dissection, and the working space is more confined. TPP gives a wider view, potentially easier for complex cases or recurrent hernias where the anatomy might be starred, and allows inspection of the abdominal cavity. But it requires opening and closing the peritoneum, with that small risk of bowel complications related to the entry or closure.
And the benefits compared to open Liechtenstein.
Generally, laparoscopic repair offers less acute post-operative pain, a significantly faster return to normal activities and work, and crucially, evidence suggests a lower incidence and severity of chronic pain compared to open mesh repair. It's considered particularly advantageous for bilateral hernias, can fix both sides through the same small incisions, and for recurrent hernias where open surgery failed previously.
What about complications besides pain? Summary box 64.90. Recurrence is still possible.
Yes, recurrence still happens, though in experienced hands it should be less than 5% for both open and laparoscopic mesh repairs. Seroma fluid collection is fairly common, especially after laparoscopic repair if the sac wasn't fully removed. And a rare but serious risk, particularly in open surgery involving extensive dissection of the spermatic cord, is damage to the testicular artery, which can lead to testicular atrophy or infarction.
You mentioned risk factors for chronic pain.
Yes, the sources note being female, younger age, having significant pain before the surgery, and certain psychological factors can predispose patients to developing chronic post-hernia pain. It's something surgeons need to consider when counseling patients and choosing the repair type.
Okay, let's shift gears to the femoral hernia. Summary box 64.11. We've mentioned it's less common than inguinal, but much more dangerous. Why is the risk so high?
It all comes down to the anatomy of the femoral canal. This is a potential space just medial to the femoral vein below the inguinal ligament. The real problem is the medial border of this canal.
Which is?
The lacunar ligament, also known as Gimbernat's ligament. It's a sharp, crescent-shaped, completely rigid, fibrous edge. When abdominal contents, usually bowel, force their way into the femoral canal, this unyielding ligament acts like a constricting ring.
Like a guillotine, you said earlier.
Pretty much. It clamps down hard, leading to a very high rate of early strangulation. Bailey and Love states about 50% present as an emergency. They're also more common in women, particularly older, thinner women.
And they're hard to diagnose.
Very tricky. They often appear as just a small lump, usually below and lateral to the pubic tubercle, lower than an inguinal hernia. Because the neck is so tight, they quickly become irreducible and often lose that expansile cough impulse. They feel firm, maybe slightly tender, easy to mistake for a harmless lymph node if you're not thinking about it.
Given the danger, watchful waiting is out.
Absolutely, 100% out. Femoral hernias must be repaired surgically, and usually urgently.
What are the surgical options?
The approach depends on whether you suspect strangulation. If it's an elective repair of a known reducible femoral hernia, you might use a simple low approach, Lockwood, directly over the lump. But this gives poor access if you need to resect bowel.
So for emergencies?
For suspected strangulation, you need better access to the abdomen. The inguinal approach, Lethecin, goes through the inguinal canal to reach the femoral defect from above. Even better, especially if bowel resection seems likely, is the high approach, McEvity, sometimes called the Nyhus modification. This involves an incision higher up, allowing direct entry into the extraperitoneal space or even the peritoneal cavity for full inspection and resection if needed.
Can you fix them laparoscopically?
Yes, both TAPE and TAPP approaches work well for femoral hernias. Laparoscopy offers excellent visualization of the whole area, inguinal and femoral orifices. This is particularly helpful in women, where differentiating between an inguinal and a femoral hernia preoperatively can sometimes be difficult. You can definitively see the defect and place the mesh to cover it properly. Hashtag tagged P ventral hernias, anterior abdominal wall.
All right, let's move to the front of the abdomen now. The ventral hernias, these can be primary or secondary, right?
Correct. Primary ones include umbilical, epigastric, spigelian, lumbar. Secondary are the incisional hernias after surgery and peristonal hernias next to a stoma.
Let's start with the adult umbilical hernia, often called perumbilical.
Yes, because they often arise just next to rather than directly through the true umbilical scar. They happen because of stretching and thinning of that midline linea alba, often due to increased pressure pregnancy, obesity, fluid in the abdomen, ascites.
And are they risky?
They can be, yes. Like femoral hernias, they often have a relatively narrow neck with sharp, fibrous edges. This means the risk of contents getting trapped, incarceration, and strangulating is quite high.
How are they repaired? Is mesh always needed?
For very small defects, maybe less than 1 centimeter, a simple suture repair might be okay. But for defects larger than 2 centimeters, mesh reinforcement is definitely recommended because suture repair alone has a high recurrence rate.
What about the Mayo vest over pants repair?
The Mayo repair, where you overlap the fascial edges like a double-breasted jacket, is a classic technique, often used for defects up to about 2 centimeters. It can work, but it often involves pulling tissues together under significant tension, which we know increases recurrence risk. So for larger defects, or in obese patients, mesh is generally preferred, often placed using a laparoscopic IPOM technique with that special tissue-separating mesh. Sometimes you have to take down the falciform ligament attaching the liver to do this laparoscopically, figure 64.2 metal.
Next up, the epigastric hernia, higher up the midline.
Yes, between the xiphoid process, bottom of the sternum, and the umbilicus. These are usually small, often less than 1 centimeter. Frequently, they just contain a little blob of extraperitoneal fat that pokes through a tiny defect in the linea alba.
But they can be painful.
They can be surprisingly painful when that little bit of fat gets nipped or partially strangulated in the defect. The biggest pitfall with epigastric hernias isn't the repair itself, it's missing others. Patients often have multiple small defects along the linea alba. If the surgeon only fixes the one obvious one, the patient comes back later complaining of pain from another nearby defect, thinking their hernia has recurred when it was actually a missed primary defect. You have to carefully palpate the whole length of the linea alba.
Okay, now for a rare one. The spigelian hernia. Where does this occur?
This is uncommon and often tricky to diagnose. It comes through the spigelian fascia, which is the aponeurotic layer between the rectus muscle medially and the semilunar line laterally. Most occur below the level of the umbilicus, near the outer edge of the rectus sheath.
And are they dangerous?
Yes, they typically have a narrow neck through that tough aponeurosis, so like femoral and umbilical hernias, they carry a high risk of strangulation. Summary box 64.15. Once diagnosed, usually with CT or ultrasound, they need surgical repair.
Finally, the big one. The incisional hernia. You said potentially up to 50% risk after laparotomy. That's huge.
It can be depressingly high, yes. Prevention during the initial surgery is absolutely key.
How do you prevent them? Good closure technique.
Exactly. The evidence strongly supports using a small stitch, small bite technique for closing the fascia. That means taking bites of tissue about 5-8 millimeters back from the edge with stitches placed about 5 millimeters apart. You also need to use the right suture material, usually a slowly absorbable monofilament, and ensure you use enough suture length. The rule of thumb is a suture length to wound length ratio of at least 4.1.
But if they do occur, repair is tough.
Repairing incisional hernias is often very challenging. They can be large, involve significant loss of abdominal wall tissue, and frequently there isn't just one defect, but multiple Swiss cheese holes in the fascia. Simple suture closure is almost always impossible or doomed to fail due to tension.
So it's mesh again, and often complex reconstruction.
Absolutely. For open repair, the preferred plane for the mesh is usually the retromuscular sublay position behind the rectus muscles, but in front of the posterior rectus sheath or peritoneum. This provides that mechanical advantage. If the defect is very wide, say more than 10-15 centimeters, you might not be able to bring the edges of the rectus muscles back together, even with mesh.
That's when you need component separation.
Correct. Component separation techniques involve making strategic cuts in other layers of the abdominal wall, often releasing the external oblique aponeurosis laterally, or sometimes the transversus abdominis muscle posteriorly, tar transversus abdominis release, to allow the rectus muscles to slide back towards the midline, restoring the integrity of the linea alba. Mesh is almost always used to reinforce these complex reconstructions.
What about laparoscopic repair for incisional hernias, usually IPM?
Laparoscopic repair is common, especially for small to moderate defects or in obese patients. It's typically done using the IPOM technique, bridging the defect with that specialized tissue-separating mesh. However, if you bridge a very large defect laparoscopically,
You get that pseudo-recurrence.
yes, the mesh itself holds, the hernia is technically repaired, but because there's no muscle covering it, the abdominal contents can still bulge outwards against the flexible mesh. Figure 64.27. Patients feel a bulge and think the hernia is back, even though the repair is intact. It's a limitation of bridging large defects laparoscopically.
We should briefly touch on some rarer conditions. What about the obturator hernia? We mentioned it's often missed.
It's a really nasty one. Passes through the obturator foramen in the pelvis, much more common in elderly, thin women, usually doesn't cause a visible or palpable lump.
So how is it diagnosed?
Often late, when the patient presents with bowel obstruction or strangulation, frequently a Richter's type. The classic clue, if present, is the Hauschip-Romberg sign, pain radiating down the inner thigh towards the knee. This happens because the hernia sac irritates the obturator nerve as it passes through the canal. Diagnosis is usually made on CT scan. Repair is essential and needs care to avoid damaging the obturator nerve and vessels.
And the lumbar hernia again.
We mentioned the two triangles, superior and inferior, petites. Hernias here tend to enlarge over time, so surgical repair is generally recommended once they're found.
Moving away from structural defects, what about severe infections of the abdominal wall? Bailey and Love mentions two particularly scary ones.
Yes, these are surgical emergencies with high mortality. Synergistic gangrene is one, a rapidly spreading tissue necrosis caused by specific bacteria working together. Requires urgent antibiotics and wide surgical debridement.
And the other, necrotizing fasciitis.
Necrotizing fasciitis, sometimes called Fournier's gangrene when it involves the perineum, is terrifyingly fast. Infection spreads like wildfire through the subcutaneous fat and fascial layers. Patients become profoundly septic very quickly. The absolute key to survival is early diagnosis and immediate, aggressive, and often repeated surgical debridement. You have to keep going back to the operating room every 12-24 hours to cut away all the dead tissue until you reach healthy bleeding margins. Antibiotics alone will not cure it.
Okay. What about non-hernia problems, specifically at the umbilicus?
Chronic discharge or sinuses can occur, sometimes related to infection around mesh used in a previous umbilical hernia repair. Very rarely, you can get persistent developmental structures causing issues, like a remnant of the Meckel's diverticulum connection or a patent urachus leaking urine.
And the most sinister umbilical lump.
That's the Sister Joseph's nodule. It's not a hernia. It's a hard, irregular mass representing metastatic cancer that has spread to the umbilicus, often from stomach, colon, ovary, or pancreatic cancer, sometimes tracking along the ligamentum teres from the liver. Sadly, it usually indicates very advanced, widespread disease, and surgery is rarely beneficial beyond perhaps a biopsy for diagnosis.
One last major condition, abdominal compartment syndrome, ACS.
This occurs when pressure inside the abdomen gets dangerously high, typically measured via a bladder catheter. Pressure over 20 mmHg is concerning, higher is critical. This high pressure squashes the organs and blood vessels, reducing blood flow to the kidneys, bowel, impairing breathing. It leads to multi-organ failure if not relieved.
How do you treat it?
Intervention is mandatory. Sometimes medical management helps, but often surgery is needed to decompress the abdomen. In severe cases, especially after major trauma or sepsis surgery where the bowel is incredibly swollen, you might not be able to close the abdomen safely at the end of the operation. In that situation, you perform a laparostomy, intentionally leaving the abdomen open, usually covering the bowel with a temporary dressing system, often involving negative pressure wound therapy. The patient then needs planned returns to the operating room for washouts and gradual attempts at closing the fascia over several days as the swelling subsides. Hashtag tag outro.
Wow, that was a comprehensive tour through the world of abdominal wall hernias, really drawing deep from Bailey and Love. We've covered so much ground.
We really have.
From the basic architectural flaws like the linea alba, making sure we distinguish divarication from a true hernia, understanding why narrow-necked hernias like femoral and spigelian were so high risk.
And the critical difference between reducible, incarcerated, and strangulated hernias. That's fundamental.
Right through to the nuances of mesh repair, the tension-free principle, why it's contracture, not shrinkage, the importance of large pores, and the challenges of IPM.
And despite all the tech and imaging, the key message remains. Good clinical history and meticulous examination, especially assessing that cough impulse, are still absolutely vital for accurate diagnosis and risk assessment. Remembering those anatomical landmarks, Hesselbach's triangle, the lacunar ligament is crucial.
It definitely is. Which brings us to our final thought for you, the listener, to chew on. We spent some time discussing the collagen disease theory, the idea that an underlying genetic weakness in collagen production contributes significantly to hernia formation, and also likely influences how well repairs hold up, given that mesh failure is often about the host tissue contracting.
Right, the interplay between the implant and the patient's biology.
So here's the question. Imagine a future where we could easily get a genetic profile of a patient's specific collagen makeup before hernia surgery. We'd know their inherent tissue strength, their predisposition to forming weak scar tissue. If that became routine, how drastically might it change our approach to hernia repair? Could we see a resurgence of non-mesh, suture-only techniques? Maybe the Scholdes, the Desarda becoming the preferred method again, but only for those patients identified as having a genetically good collagen profile, capable of healing strongly on their own. Would personalized medicine extend even to the choice between sutures and mesh?
A fascinating thought. Tailoring the mechanics of the repair to the biology of the patient. Something to consider.